Our next speaker is going to be Dr. Frankis Almaguel. He's a distinguished diagnostic radiologist and nuclear medicine physician scientist, also with a PhD, who completed his Bachelor of Science in Biology in the Universidad de Puerto Rico, San Juan campus. Dr. Almaguel completed his medical school, PhD, Neurophysiology Fellowship, and Diagnostic Radiology Residency, all in Loma Linda, University School of Medicine in California. He completed fellowships in nuclear radiology, as well as in molecular imaging and therapeutics, both from Wake Forest Baptist Medical Center, North Carolina. He is an associate professor of radiology and basic sciences, and the director of molecular imaging and therapeutics research program at Loma Linda as well. He's the principal investigator of several first-in-human and early-phase clinical trials in molecular imaging and theranostics, and is chair of the prostate cancer outreach of the Society of Nuclear Medicine and Molecular Imaging Targeted Radionuclide Therapy. He has authored numerous peer-reviewed publications and is currently a National Cancer Institute-funded investigator. He currently holds several patents that are pending approval.
How many of you know about prostate cancer? How many of you know a patient of prostate cancer? How many of you believe that we need to do something better for prostate cancer? All right, then you're in the right crowd. It's been a humbling experience from a few years to today. And I'll tell you a story before they bring something here. I had a patient in 2021, months before the first commercial PSMA was done in the US in terms of like the insurance will pay for. So this patient traveled all the way to London to get a PSMA PET-CT. And when he was walking into the office where they're gonna do the injection, the dose, the little vial, slipped from the hand of the technologist. And you know how hard it is to find another dose? How many doses do we have? 2 to 3 per day. So that guy traveled all these miles to get this scan, and there's no dose. Fortunately, they were able to tell a British patient to come next day, and he got the dose. But my point was, we come a long way where you can have a PSMA PET-CT here, and you don't have to travel all over the world just to get the pictures. And why do we get these pictures? We get these pictures because we believe they can enhance the therapeutic interventions and the outcome of the patients. So I think my picture should be coming pretty soon, so I'm excited. Good work. I haven't made it easy on him. So after working with prostate cancer patients for a long time and treating hundreds of patients with PSMA radioligand therapy since 2018, I will tell you, this is just the beginning. We're going to have this grow from prostate to all other cancers. Currently, I have trials on basically every cancer you can imagine doing the same thing. So when you see here PSMA, think about it's just a biomarker, and we can change it, and we can do very interesting things. Thank you, sir. Appreciate it. All right. Are you ready? So I think my objectives are going to be very small, but also no disclosures will change anything today here. The point of this slide is that we have a problem, and cancer is a big problem. Maybe second kind of problem we have, but it's a pretty big one. And I would tell you, if you know somebody with cancer, then you understand that we're not there yet. So let's just walk together here, and let's just focus on a small cancer, prostate cancers, which is very selfishly affecting males more than women, because we have a prostate and women don't. So it is scary because we have a lot of cases, and if you look at here, it has significant mortality. So let me tell you how this works. And you can stop me and ask me a question if you need to, but you can have and I forgot to put pictures here, but you can have a prostate cancer that is this is group 1, 3+3. For me, that's a poodle. Anybody knows a poodle? These dogs that are really cute that are never going to bite you, you know? They're really nice. They can get lost, so people steal them because they're so cute. You have a cancer that is group 5. That's a Rottweiler. Have you seen anybody stealing a Rottweiler or a Doberman? They don't. They just walk away. These are cancers that if you don't treat them, you're going to have problems. With the low-grade cancer here, you could die with the prostate cancer, not of prostate cancer. It's a big difference. And I will tell you, this imaging that is becoming a reality today is allowing us to not treat everybody the same, which is very important. So when you have a high Gleason score, Gleason means that the cells are becoming a lot more crazy, right? These are cells that are almost close to the prostate cancer cell versus these ones that are irregular and neoplastic and they go somewhere else. So that's the attempt of making this very fast and very simple. But the point is, when you have a prostate cancer that is outside the prostate and it's metastasized, it's a big deal. This cancer is a threat to the life of our patient. And if you look at these numbers here, and this is 2021 data, we have a significant problem. And when you have 600,000 plus people dying every year, then you have to understand that we have a lot of work to do. We need better diagnostics, better treatments, better physicians putting their heads together to work and fight this. All right. Cancer is not that different from your own cells. That's why they can actually hide in plain sight. And sometimes some of our therapies are wiping out everything close to that cancer. And that's a problem, because what would happen if, because I want to take care of one troubled tree, I destroy the whole garden? It's not nice to the other trees, right? To the other ones nearby. Same thing here, and we have a lot of the side effects that you see from cancer treatments. It's not because it's not killing the cancer, it's because it's killing the normal cells too. So, oh no. Wow. PSMA, this has to be fixed. Sorry guys. This is the issue with my, all right. This is the issue from the Mac to the PC. Prostate-specific membrane antigen. Have you heard about that before? Some of you have. So it's basically one transmembrane protein that is bringing lots of nutrition for a very hungry cell. Because cancer cells, they just want to divide and run. And they bypass a lot of the normal cellular functions just to make sure they get ahead in dividing. And this protein is overexpressed up to 1,000 times more in prostate cancer than in normal cells. So guess what? We're using that characteristic to actually help our patients. Now we know where the cancer is, and if you know where the cancer is, guess what? You can zero in on the cancer and be very specific. So the therapist will get to the cancer cells, not to the normal cells behind, all right? So the really interesting thing that happens now you have the right biomarker. You can actually now play around with something that is called theranostic, and all this, I will describe that in a little bit, where you can play around and switch therapeutic isotopes with diagnostic isotopes. So to pause for a second, this is a low-grade cancer with a little bit of PSMA expression, very small amounts. High-grade cancers, high Gleason scores, high-grade, a lot of PSMA. And you see, if you have a lot of PSMA expression, these patients have a decreased survival. And patients with very little PSMA expression, like here, they do well. They die with prostate cancer, not of prostate cancer. And this has been there's been documented, and you can see the whole body histopathology here with that PSMA PET-CT showing you where the cancer is. Now, let me stop and walk you through, because for some of you, this is Chinese, right? You have no idea what this means. But let me make a introduction of two PET-CTs. Okay. Who's an oncologist in the room? Perfect. For you, it'll be very easy. Which one is the FDG PET-CT? I put it here, but you see that brain there? That's because FDG goes, the brain likes glucose a lot, right? So then you have the PSMA PET-CT, where the normal biodistribution is the salivary glands, lacrimal glands, the kidneys, of course, because it's excreted through the kidneys, and the bladder, right, where everything goes out. A little bit on the kidneys and in the liver, but FDG has a completely different biodistribution. That's why we could say, we know exactly what it is from the back of the room. But for completeness sake, let me ask, let's have a poll here. If you have a prostate cancer patient, which PET-CT do you order? You should order this one. This FDG PET-CT should be reserved to very special situations in prostate cancer, and so small that you don't want to even mention it. But there is a difference, and there are some specific guidelines that we want to follow to order those PSMA PET-CTs, just to be good stewards of the resources of our people. We want to have these PET-CTs done on patients that have this at least intermediate unfavorable disease, which is, you understand that is, you have a lot of concerns that these patients, if you detect a metastasis, will change the management of that patient. So molecular imaging. Maybe I got a little bit ahead of myself, but molecular imaging is what allows us to do this. Why? Because we are able to look into the depths inside the cells and see their metabolism, see how the small molecules inside, see what are they doing. Look at the PSMA transmembrane proteins and the expression of those cell membranes. So I don't think you can see where the cancer is hiding here, but if you understand the molecular changes, the functional changes will happen way before the structural changes. That's why you could see a lot more with the molecular imaging than with the structural imaging. And I think it's very clear, I don't have to explain to you too much, that this is, you can see the cancer much better here. Now, this is one of the cases where everything changed, for me at least. This was a patient that was coming to the clinic with rising PSAs, and we were telling him, we just can't see the cancer yet. Go home, come back. We just didn't have the right technology to see that. And if you look for a wolf here, Anybody can see it? You don't, right? Because you need the right technology to see it. So this scan was done the same month, a couple weeks apart. And this was the difference. So think about you as a physician telling a patient, you know, I just can't see it. The patient say, hey, I have pain everywhere. What's going on? This is why after 2022, where all the PET-CTs, PSMA PET-CT were approved, nobody's going back. You want to have the right diagnostic imaging to make the right decisions. So I am going to just pass on this, but I can tell you, you don't have to have disease everywhere. Actually, this PSMA PET-CT is better when you have very little amount of disease, because that means you could change management much quicker and with better, more meaningful interventions. So these molecular imaging glasses are allowing us to make a huge difference. And don't take it from me or from the pictures you saw. These are peer-reviewed publications with data showing that these pictures are not just pretty, these pictures are not just informative, but these pictures are helping doctors make decisions that will improve patient outcomes. And you can see that the higher grade patients, the high grade cancers that come in, the doctors change their mind about the management of the patient 62% of the time. So that means you say you have a patient, you say, I'm going to do surgery. The patient has signed consent for surgery and is ready for surgery, and you do this PSMA PET-CT, and you say, sorry, I cannot do surgery anymore. Why? Because the cat is out of the hat. You will hurt the patient instead of helping him. Or other interventions, right? So this is not on, this applies to radiation therapy, this applies to focal therapies. The bottom line is, you were thinking that the disease was here, and indeed was somewhere else. So that means you're helping patients by having the right tools delivered to the doctors. And we'll talk about that later. But we do much better when you detect the cancer really early. When you're able to detect a dot, I can tell you, you can have a much better chances to helping this patient do much better. If you wait until the disease is everywhere, when you see the disease in the bone scan, it's just too late. And I tell my patients, you know, I had a patient just Monday, right? And he's like, I want another therapy. I'm like, I can't, because you're doing great. I don't see any more PSMA uptake. Your PSA is really low. You want me to do something that I just would not do for my own dad, right? Because this is the joke I have, and I tell my patients sometimes, like, if I cannot make you better, I can always make you worse. So you want to have the right treatment for the right patient, and you want to use all the information you have. That's why multidisciplinary teamwork is imperative. So you want to do the treatment, you want to find out the cancer really early. And this is a slide for the future. In the future, you will not be calling breast cancer, prostate cancer, pancreatic cancer. You want to be calling by a molecular phenotype. So estrogen receptor positive, PSMA receptor positive, FAP positive, or integrin, or whatever biomarker you have, and you can deliver a therapy that is going to be effective regardless of where the cancer is or where it has originated. The idea is to eliminate trial and error from medicine. You can remember the days where we send you home, and 3 months later come back, see what we have done, and if you did great, we celebrate. If you did worse, we change the therapy. Now we believe we can achieve a little bit more precision. But let's say that you don't understand and you don't want to believe that this is the future. I want to urge you that the future is also coming, this precision is also affecting costs. If you detect the cancer when it's early and localized, you spend a lot less resources. If you wait until the cancer is all the way here, the side effects of financial toxicity is even worse. So, I don't want to scare you, but per year we're spending up to $8.2 billion just on prostate cancer. And I think we can do better. We are changing from conventional to advanced imaging. That means we're going to have a lot more options. And you will have to change the way you do your orders. You cannot say, give me a PET-CT, or the preparations for the PET-CTs are different. So now you're going to have to ask for an FDG PET-CT or a PSMA PET-CT or a DOTA-tape PET-CT and so on and so on, because we're becoming more, we have more options. So here, these are 1, 2, 3, 4, 5 PET-CTs that we do for prostate cancer. And you're going to have to know that some people have some preferences, but the idea is we have a lot more options. And let me walk you through a couple of scenarios. And this is what this imaging is doing for our patients, right? The sensitivity, this is the Osprey trial, sensitivity of this and the positive predictive value of PSMA PET-CT is fantastic. The problem with PET-CT is that it might not have the best negative predictive value, because if the scan is negative and I cannot see the microscopic disease, I cannot tell you don't have cancer. But if it's positive, you have it, and we have options for you. And this STOMP trial basically says that if you treat the area where that PSMA positive disease was, the survival of these patients is increased. And the same thing was done by the Oriole trial, where if all the PSMA positive lesions were in the range of in the area of the radiation, this patient has significant advantages from the patients that did not have all the lesions covered. This is one of my patients. This is a very active physical therapy professor, and he was diagnosed, and this is what he was found. He was able, of course the bone scan was negative, the CT was negative, but if you see, the cancer is right there. He had local treatment and he's been doing fantastic for now 7 years or so. At the same time, if you don't have the right technology, you could be doing treatments that will hurt our patients because they're not going to benefit from it. So this is one of the cases from the scanners in this room. This is Dr. C's patient, 62-year-old with history of prostate cancer. He had a prostatectomy and non-focal extraprostatic extension with perineural invasion, 7 vesicle invasion. So negative lymph nodes, now presenting after surgery with a 0.24 PSA. This is really just above the threshold of calling to do a PET-CT. And you found this perirectal lymph node, these 2 3-millimeter lymph nodes were found, and this patient got PSMA-guided radiation therapy, and the PSA became 0 again. Is that right, Dr. C? When you see cases like this, you understand that the investing in technology pays off directly to our patients. This is another case. 63-year-old, history of prostate cancer, negative margins, negative lymph nodes, now comes in after prostatectomy with a PSA of 0.44. and you look at the whole body, and you find one pelvic node that is around 3 millimeters, and the same response. If you are that patient, you should be very grateful that you have a good quality imaging equipment. Because Dr. Mosci, what was our traditionally we say that PET-CT cannot see things, cannot see nodes below what? Below like 7 millimeters, right? Now we're going even lower, and the future is really interesting, right? So this same thing here, right? We found these small lymph nodes that now you could do direct targeted interventions, increasing the patient's chances of survival. Again, another study from this, another scan from this, using the same equipment, and you can see very small expression of PSMA in these small nodes that will make all the difference. In addition, this keeps going, right? Once you are seeing the pattern is we are diagnosing more and more cancers really early. That means we're giving these patients chances to do much better. The theme of the story is that you're finding these cancers earlier, and these patients are getting better, targeted, precise interventions. This also helps the surgeons, right? Because the surgeons need to see. You don't want your surgeon doing surgery blindly. Sometimes we have asked them to do that. But now we have so many procedures on the line where a precise location of the cancer will help surgeons make a better decision and the patients get a better outcome. This case, very interesting. In the actual area where the trocar was put to take the prostate, a single metastasis was found after the PSA came with raising PSA. The surgeon went and took it out, PSA disappeared again. So you're guiding surgical interventions too. But the world is still changing, and do you know that fear of change is one of the biggest fears of humans? I think that and public speaking are one of the top ones. And we hope we can do different things with the knowledge we have today and with the access that we have today. So when you see, they send me this case from the United group, and you can see this is very easy to see that this is everywhere. These are the cases that you don't want to see. You want to see them a lot earlier, and you want to give these patients the options. But it's still there. It's a reality. And you can see patients with a lot of disease coming to you. I could tell you that the next generation, this is done in the third generation of PET-CTs, you can see that patients that before couldn't withstand having a PET-CT because it was taking too long, here we can do it much faster. And you can see the quality. You're not throwing away quality because you have a lot more sensitivity, better crystals. And the idea that I want to pass to you is that we have more and more technology passing to the physician so we can make the best decisions. So now we had got together and we had decided that the guidelines had to be changed because it's not fair for the payers, it's not fair for the patients, for us to be doing other scans in prostate cancer when you know that the bone scan and CT might not see your disease. You just go straight to the PSMA PET-CT, and now you can do it. Before you couldn't. I mean, now you don't need to have conventional imaging done as a requirement. So this is something that is going to be found somewhere else. But let me talk about theranostics for a couple of minutes. It's a revolution that puts in therapy with diagnostics. The diagnostic test that you just got will affect or will trigger a therapeutic intervention if you have the right biomarker in your cancer cells. And how does it work? So you have an imaging isotope that is bound to a linker that acts like a key and in a lock. And you see here, it tells you where the cancer is. Now when you have, with the PSMA PET-CT, you have shown that this patient has PSMA positive disease. Now can you go ahead and change that imaging isotope for a therapeutic isotope? And I had so much fun designing this. If you look closer, I put here like a micronuclear bomb, you know, the just nuclear, you know, you understand? And I don't think this is gonna work. Oh, it might work. When I made that little video, I don't know, 6-7 years ago, I was just very interesting because you could send micronuclear bombs all over the body going to destroy those cancer cells. It's like a smart bomb going and finding the cancer. This is still very interesting for us. And how does it work? These isotopes that emit beta or alpha radiation will go and break the DNA of these cancer cells, because the cancer cell will take all this PSMA, which is basically nutrition for, you know, this transmembrane protein is going to bring in glutamate and folate. Now it brings in this poison PSMA, or this radioactive small molecule that goes and destroys the cancer cells. And very simple, our motto is that if you can see it, you can treat it. Now, you gotta be very careful, because now sometimes I don't see it and you still can treat it, so you gotta be very careful. I don't want to talk about that too much, but these are two of the cases of two patients that very dear to my heart. I still see them every few months. So this 64-year-old back then now is a little older, 6 years older. But if you see, he was diagnosed with disease everywhere, and after 3 cycles of PSMA ligand therapy, his PSA came from 800 to 0.01. And you see this cervical spine lesion that his oncologist and his physician say, hey, if you walk a little funny and fall, you might be paraplegic, because the whole vertebral body is full of cancer. And I was bold enough after I saw this, and after he was doing so well, to allow him to, well, not allow him, but he could go back to skiing with his kids again. And this is the series of treatment that he had. As you know, this of course was done in a clinical trial setting, because it's a lot earlier than the approval of the PSMA therapy. And you can see this is the diagnostic test. You can see the cancer, right? The PET-CT that I just showed you. And now this is a post-therapy scan, where you are actually seeing where the therapy is going. So the days where come back in a few months, see what happens. No, you can see it. This is a few hours after the scan. And you did that in between your treatments, and you can see with this SPECT-CT, you can see the responses that we're having. So in the future, we're going to do a lot more dosimetry, and we're going to do a lot more post-therapy scans, and this is going to be good for patients and for our payers, insurance company, because we're going to help in terms of conserving resources. And why do you don't repeat PET-CTs just for repeating them? Because if you have a PET-CT, if you have a patient that wants a PET-CT but his PSA is 0, you have to be a good steward and say, hey, I don't want to do something that is not going to show me anything. It's going to be good for me, for data, to show you more updated pictures, but it's not, so it's not good for everybody. So Alan was able to go and see the Society of Nuclear Medicine and talk to all the therapy and industry, and it's pretty interesting. He goes everywhere talking about prostate cancer, even been to to the Capitol Hill with me, talking to senators and things. But there's another patient also. This patient, his wife called a friend at the university, and he said, "Look, my husband is dying, and I know he's dying because he's selling all his toys, like his motorcycle, and he's selling everything, and I know that there has to be something for him." So from the highest PSA I ever seen to a few months later, this is basically 9 months later after the PSMA ligand therapies, he got 6 therapies. He's doing a lot better. Actually, in 4 days after the therapy, his pain was gone. So one of the side effects of this therapy is that it helps with pain. And you can see from 1 month to a couple months later, the significant decrease in the extent of the disease. And this is him just this summer talking about his experiences, talking to everybody to make this more available for patients, because he feels really lucky that he had access to that, and a lot of his friends didn't. So precision oncology, that's where we want to go, and we're getting there with the right setup. And I want to stop there because the time is up, but there's a lot more to talk about, and I wanted to end saying that this is just the tip of the iceberg. We have a lot more to show and a lot more to do, so hang in there for the ride. Thank you.
Initializing scan.